Good evening. My name is Corey Nettles, and I'm the chairman of the Board of Trustees for the Medical College of Wisconsin. We thank you for joining us again for what are now our standing Monday evening town halls. We've heard from you. Some of you are repeat attendees that you find these forums to be informative, and because you still find them useful, we're going to continue to do them as a service to our community. Obviously, we remain in extremely unprecedented times, and if you're like me, you're bombarded every other hour, it seems, with new information, new data, new facts, new projections, new scenarios about the effect of COVID-19 on our country and here in our community. At the Medical College of Wisconsin, we remain committed to being a trusted source of truth and information that we provide all across our community to all stakeholders and to all audiences. And toward that end, it's our great pleasure to be back here with you again this evening. We have, again, a terrific lineup of panelists, including some repeat performers who've gotten to be quite expert at this. And we have one new attendee who I hope will be joining us shortly. First and foremost among them is Dr. John Raymond. He is the president and CEO of the Medical College of Wisconsin. We also have Dr. Joyce Sanchez, who is an infectious disease physician and expert at the Medical College of Wisconsin, joining us again. And we hope a little later in the broadcast, Dr. Tito Izard will also be joining us of Milwaukee Health Services, Inc. So Dr. Izard, we hope will be joining shortly. As in the past, we invite you to submit your questions through the question button, and we'll get through as many of those as we can at the end of our discussions, but throughout the evening. And we found those questions to be insightful and a challenge to us, and we hope informative to you. So without any further ado, Dr. Raymond.
Okay, thanks, Corey, and welcome everyone. We hope to have some time to answer your questions. We've enjoyed and learned a lot from the questions, and we think that's probably the most important thing that we can do. Just to set the stage, though, we do want to update you from the last town hall meeting, and I'd like to start with our report card. As many of you know, over the last 3 weeks, we've been tracking the progress we've made to stop the spread of COVID-19 here in Wisconsin, and we followed two indicators. The daily growth rate measures the percentage of new cases that we have every day. And for the daily growth rate, a lower number is better. The doubling time is the predicted time that it would take to double the number of COVID-19 positive cases in our state or in our region, and a higher number is better there. And we've seen steady improvement in both of these measures, and the favorable trends continue today. As of today, there were only 33 new COVID-19 positive tests in Milwaukee and 87 in Wisconsin. The daily growth rates are better too, improving to 8.8% in Milwaukee and 9% in Wisconsin. Now, by comparison, 3 weeks ago, the growth rate was almost 35%. So this is tremendous progress. The doubling rates originally were lower than 3 days when we started measuring them about 3 weeks ago. And those have improved and stretched out to about 7.9 days in Milwaukee and 7.7 days in Wisconsin. Again, this is tremendous progress. In terms of what you've done to flatten the curve, Wisconsin now ranks in the top 10 states in our country. Great work, everyone. And thank you for the sacrifices that you've made to help us flatten the curve. Next slide, please. This next slide shows the daily new COVID-19 positive tests reported in Wisconsin over the last month. As you can see, going from left to right, there appears to be a flattening of the new reported cases in Wisconsin. Milwaukee's trends look very much the same. So it looks like we're trending in the right direction, but we really don't know yet the impact of the in-person elections held 6 days ago, or of the relaxed social distancing over the religious holidays this last weekend, when many people decided to enjoy time with their extended families who don't live in their household. Now, we wouldn't expect to see an impact until about 7 days out from either of those events. So we'll be watching out for that, but we're hopeful that we're making good progress. Next slide, please. So what do we need to do to keep safe as the Safer at Home order expires on April 24th? Really, we need to see over the next few days a reduction of the cases over 14 days. We want to see testing availability for all individuals who have symptoms of COVID-19, so that needs to improve. And we need our hospitals to be able to care for individuals who need hospitalization. And finally, we need to make sure that people have enough personal protective equipment for people that are working in public places. That could be a cloth face covering, but it also could be for frontline healthcare providers and first responders, surgical masks, N95 masks, and face shields. Next slide, please. Eric, if we could go to the next, thank you. So I'm sure you're asking, what can you do to help us keep safe as we move forward, and hopefully we begin to resume some normal semblance of work. But we all need to continue to wear cloth face coverings in public places, to wash our hands for at least 20 seconds with soap and water, or to use alcohol-containing hand sanitizer. And we need to continue to keep our hands away from our faces, mouths, eyes, and nose. And finally, for people who don't live in your home, you need to do as much as you can to stay at least 6 feet apart from each other. So with that, I'd like to turn the presentation over to Dr. Sanchez. Next slide, please.
Dr. Sanchez, would you unmute? Sorry.
Can you hear me now? Okay, thank you. Thank you, President Raymond. I'm very excited to share with you some of the latest data that's come out on COVID-19. Testing strategies still scaling up, but still not where we need them to be for everyone to have testing that needs it. The first type of testing platform is a nucleic acid-based test, and that's detecting direct viral RNA, so the genetic makeup of the virus. The second is a serologic test, which is not here for prime time yet, but is up and coming now. One has been FDA approved for use in the United States, and many, many more commercial laboratories, including Wisconsin Diagnostic Laboratories affiliated with the Medical College of Wisconsin. That test is to test the presence of antibodies, so exposure to the virus that causes COVID-19, and potentially can be a marker for immunity down the line, although that is yet to be hashed out definitively. Some of the therapies that we're using, including two which are new this week to the Medical College of Wisconsin. The first is called remdesivir, and that was a drug that was used for experimental treatment for Ebola virus. There is some hope that it has some direct effect on the SARS-CoV-2 virus that causes COVID-19. We are also still using an off-the-shelf medication called hydroxychloroquine. That's an anti-malarial. It's also used to treat inflammatory arthritis. Some of the signal in the latest data is a little bit less promising, but we are still offering it because on a Petri dish, it still has some activity against the virus. What I'm very, very excited for is the use of convalescent plasma. You may have heard about that in the news. And convalescent plasma is a blood product that's taken from an individual who has been infected with COVID-19 at some point and recovered. And what it does is pulls the antibody or the swords of the immune system. So we can deliver it to people who are acutely ill in the hospital, who are extremely sick, in the hopes that the pooled antibody from the donor can help fight off the virus from replicating and cause that person to recover quicker without as many sequelae or complications down the line. There are also some immunomodulatory therapies that target the overabundant inflammatory immune system that can happen on later in the disease, like in week 2 of the disease. The vaccines are really the holy grail of where we really want to push research efforts. So between 35 and 40 companies across the nation, including academic institutions, are racing to create vaccinations. 4 of these have moved over past laboratory testing. 2 of them are now being used in phase 1 clinical trials in humans. So more data on that is forthcoming. Some of the greatest opportunities we're seeing are those that have been developed for other coronaviruses in the past, and we're hoping to repurpose them to see if they'll be effective while also being safe for use in humans. So we'll see more data on that in the next coming weeks. Next slide, please. We still get a lot of questions, very fair questions, very good questions on how to care for someone who is sick in your own home or someone who might have coronavirus. The first is always to wash hands and to frequently decontaminate surfaces. These include high-touch surfaces such as doorknobs, the spigots off of your sinks, the countertops in your kitchen, the refrigerator door, places that you're touching frequently. If someone is sick in your home, try to keep a safe distance of 6 feet or more whenever possible. When people are sick in your home, if at all possible, try to keep them to a separate place. So a separate bedroom, a separate bathroom, if that is an option for you, somewhere sequestered away from the rest of the healthy individuals in your home. Whenever you're caring for them, it's advisable to use some kind of mask or face covering, and that they should also use a mask or face covering because coronavirus is spread through droplets that can contaminate you directly or indirectly via contaminated surface. Don't touch your face. I tell my kids no touchy, and they seem to giggle at that. Talk about the dangers around coronavirus. There are a lot of places that you can go to for information. The Medical College of Wisconsin has a very useful website with tutorial videos, with information sheets, and language in Spanish is forthcoming too. Those are trustworthy resources, as well as the Wisconsin Department of Health and the Center for Disease Control and Prevention. Thank you. I guess we'll go to the next slide.
Welcome, Dr. Izard.
And with that, I'd like to...
Go ahead, please, Dr. Sanchez.
Go ahead. With that, we'll have Dr. Tito Izard take it away for us.
Well, thank you. I was glad I was able to join as a panelist instead of an observer a few minutes ago. So thanks for the invitation to Dr. Raymond Medical College of Wisconsin. It sounds like a great conversation that you've been having over the last few weeks, and I'm happy to join the conversation. So I was asked to speak briefly on what we're seeing at the community level. I'm a practicing family physician as well as president and CEO for Milwaukee Health Services. We're one of the federally qualified community health centers here in town, pretty much near you in the community, to ensure that everyone in this community has access to high quality health care regardless of your ability to pay. So at the grassroots level, at the community level, one of the biggest challenges that we're seeing is making sure that people have access. So many times people have asked me, well, why do we have such a large presence of the COVID-19 virus in the central city, initially predominantly very heavily on the north side of town. But over the last few weeks, we've been able to see it continue, unfortunately, to grow to mostly the near south side also. So a very high concentration of the virus being present in Milwaukee. And when we look at the African American population, which we know makes up about 40% of the Milwaukee community, when we look at things such as, so looking at some of the causes that may be contributing to why African Americans in particular, is number one is the issues of health disparities. So when we look at all the risk factors associated with someone potentially who is infected with the virus, having worsening of symptoms and requiring hospitalization, those chronic conditions such as cardiovascular disease issues, related issues, those issues of respiratory like asthma or COPD, which we often call emphysema, issues of hypertension, issues of diabetes. And then when you match that with situations such as pregnancy or someone who's greater than 60 years of age, or someone who may be immunocompromised because they're on medications or they may have sickle cell disease, or they're taking medications for their rheumatoid arthritis that make them immunocompromised, or someone who has cancer, which we know in the African American community, there's a higher incidence and prevalence of cancer in our community. So when you start looking at all these various things that can make a person's overall situation worsen with the contraction of the COVID-19 virus, then we see why we're going to see a much higher incidence of hospitalizations and ICU from the population. So when you look at health disparities issues, when you look at the fact that for African American population, there are less relationships with a primary care provider, especially for African American men, that they may not have someone who they have a regular relationship with. So by the time you start having symptoms, you don't have somewhere to call and someone to talk to. When we look at issues that most healthcare providers are in it for the right reason and they really want to care for their communities. But unfortunately, we still see in our communities the implicit bias that may be expressed at the level of the practitioner or provider, and then the institutional racism that still exists within the healthcare system. And it's important that we continue to work collectively as a community to address these issues and to provide education and training to students and various medical students and other learners, as well as to those who've been practicing for a number of years, and help them see how their actions and activities may result in either treating people differently or may result in the community not coming to seek out healthcare early enough. Then other types of issues that we see that's important is, which is kind of the driving force, is the economic condition. When you think about African Americans and the economic components that drive so many of the social determinants of health, it's so important to understand. Then that's why I said we really truly need a restorative health equity plan in this country. This is something that's been discussed for many years, and we've tried to address it in little pieces, but a comprehensive restorative health equity plan is really needed to address the economic conditions that are underlying, because it's not your income, it is your wealth position that stabilizes you. And we're seeing that now where families really can't afford to be off work, isolated for 2 weeks, and the overall impact that it's not only going to have on their health, but it's going to have on their whole family's survival and well-being. So hopefully as a community, we can continue to discuss this issue and make sure that everyone has access to high quality, affordable healthcare. Another big challenge that we'll have to address is, what do we do with people right now who don't have a primary care provider? So if you start developing new symptoms now and trying to find a new provider in the COVID-19 age, it is extremely difficult, whether you have insurance or not, to try to establish care. And we have to ensure in this community that people are not being turned away. Thank you.
Great. Well, to our community, we'd be happy to entertain your questions at this point. This has often been the most active and lively part of our town halls has been the Q&A. So we'd be happy to receive your questions. Eric, do you have any questions in the queue already?
There are several questions, but I think Dustin's going to be asking them tonight. Dustin?
Okay, go right ahead, Dustin. Sorry.
Yes, thank you. That's fine. Yes, we have a number of questions coming in, but please do feel free to use the question panel to submit more as you think of them. Our first questions that we're going to go with tonight have to do with testing. So firstly, does Wisconsin have rapid testing yet?
This is a good question. It depends on what you mean by rapid testing. If you're talking about the 15-minute turnaround time test, that's probably not ready to roll out, but there are many health systems trying to bring it forward. But I would say that a lot of the health systems are working together to give you less than 24-hour turnaround time. So that, compared to where we were 3 weeks ago, is pretty rapid. You know, Dr. Izard is on the front line, so he probably can talk a little bit more about the work that he's been doing to try to get that turnaround time reduced.
Yeah, and working with our hospital partners. So I work in a clinic, and what happens in the ambulatory clinic where you typically go to see your healthcare provider is a little bit different than what actually happens in a hospital setting. So as a larger community, the hospitals, in conjunction with the federally qualified community health centers, as well as their own clinics that are affiliated with the hospitals, have been working to make sure that everyone has access to timely, what is referred to as diagnostic testing, which means that someone has symptoms and we're using the test to try to confirm the actual diagnosis. there is not a screening test available, and there really isn't a rapid, as Dr. Raymond was just saying, there really isn't a rapid test that you can find out in the office that's currently being utilized. Right now, we're seeing with the number of the labs around the city, some of those tests, depending upon how many are coming in that particular day, the test can be turned around in several hours to up to 24 hours in many cases. So just depending upon where you're going to receive your health care, we're doing pretty good in getting that turnaround time down from 8 and 9 days that was happening earlier in the COVID-19 incidents.
The next question is related to antibody testing. So when do you think an antibody test will be available for the general public to see if they potentially already have had COVID-19?
Well, I'll start off and maybe Dr. Raymond can speak on that also, and Dr. Sanchez. So there are a number of tests that are already out there that are starting to be distributed. I think what most of us, and as far as providers are doing, is we're trying to look at those tests to try to see how useful they will be. Again, it's a test that will be used just to evaluate whether you've been exposed to the virus and now your body's developed antibodies. But we have to really make sure that our community understands the limited value of that test. For one, just because someone has developed antibodies, it doesn't necessarily mean that you are 100% immune. There's different strands of the COVID-19 virus that are out there, and those are some things that we have to have a better understanding of. So yes, antibodies might give you an initial idea that you've been exposed somewhere, that you may have mild symptoms or no symptoms, but we will have to make sure that we caution people and not acting too recklessly in their life and think that you can do anything and find yourself getting sick. Dr. Sanchez, were you going to comment on additional?
Yeah, I can echo what your concerns are. So antibody testing can be a useful adjunct, especially in this day and age where we don't have as many nucleic acid amplification tests available because of supply chain issues. The antibody test really does not come up as positive until a week or two after someone has been exposed to the virus or longer. So it is not as useful in the acute phase of illness where you have respiratory symptoms or fever and want to know if those symptoms are due to COVID-19. It'll pop up as positive later on in the illness. And like you said, just because you have a positive antibody test does not guarantee that you have a protective immune response. That's yet to be hashed out. Where I see that going to be a lot more useful down the line is when we are screening people who have had COVID-19 symptoms and are looking to be plasma donors. If they have a positive antibody test, that will help to confirm that they've been exposed and may be eligible to donate their plasma to help sick individuals who are acutely ill in the intensive care units and on hospital floors. The antibody testing is also made by a commercial lab, and many commercial labs are coming up with their own antibody test. And the problem with that is, although that increases accessibility, each lab has to perform their own validation, and there's not federal oversight over it before it's released onto the market. So for each lab, they need to determine how good the test actually performs, whether or not it cross-reacts with other coronaviruses or other viruses in general, and how sensitive the test is when they compare it to people who are proven to be COVID-19 positive through a RNA-based assay.
As a follow-up on the mention about the different strands of COVID, are there different strands that are more fatal than others? Are they checking to see what strand is causing the fatalities?
Yes, people are checking, but the mutation rate of the virus is really slow, and it doesn't seem to affect any of the clinical outcomes. So I don't think that there's a significant difference in the strains other than maybe whether the antibodies would react with them or not.
If you tested positive for Lyme's disease, does this compromise your immune system and make you more susceptible to get COVID? Will the antibodies from Lyme disease affect the testing at all?
The antibodies probably won't affect the
I can-
testing. Go ahead, Dr. Sanchez. I
Sure.
doubt that it's going to really.
I completely agree. I agree with you. There's no reason to suggest a bacterial infection where you develop an antibody to is going to cross-react with a viral infection. Those are two completely different arms of the immune system, even though they both have antibodies that react to them. Of course, you know, we have very limited experience with antibody tests right now. So as far as cross-reactivity with other coronaviruses, including the ones that cause the common cold, there's 4 other strains that do that. We think that our antibody test, that once we have one available that's validated by our own lab, is going to perform well. If it doesn't, then we're not going to use it. Doesn't make sense to, but promising things, and I'm not worried about cross-reactivity. As far as Lyme disease is concerned in terms of your immunity, unless you have some other predisposing medical condition that may make you more susceptible to severe infection in general, Lyme disease, having had the disease and having recovered from it in of itself does not compromise your immune system in the traditional sense that we would see that it would be compromised to develop more severe COVID-19.
Okay, thank you. Do you think it is helpful for the media to be reporting the deaths of COVID patients every day? Does it help keep this in perspective as compared to other illnesses and other causes of death?
Well, I think it's just inevitable based upon the novel coronavirus. So because it is something new, if the information wasn't being presented daily, people would wonder, what are you trying to hide? So I think sometimes, well, I think actually most of the time, people can actually handle the truth. And as long as it's couched in the context of a much larger conversation, I think it is appropriate to report it daily. As a regular person who's trying to live your life and take care of your family, your kids, you know, do you need to know what the numbers are every single morning? Absolutely not. I think the numbers are helpful at the community level for what I do and what the other doctors, what they do at their level. It's helpful for us to be able to make preparations and planning. But I think the average person, if you roughly know what's going on a couple times a week, that's plenty.
Okay, what are steps that Milwaukee leaders can take to mitigate the health disparities for this epidemic? And I mean steps that will have an impact in April, not have an impact the next time this happens.
Yeah, that's actually a great question, and is obviously a very difficult and complex question, because we're saying what should we have done, you know, over the last decade or something like that, right? And now we haven't. So some of the things that we can do today to really try to do the best we can with what we have. You know, we obviously have limited resources available for testing. We obviously have other types of limited resources. So one thing that I've been encouraging is right now with our various leaders, whether it is healthcare space or whether it's the public health leaders or our political leaders and business leaders, I think it's extremely important right now to identify those grassroots community organizations who have a lot of credibility working with people in their own homes, in their own neighborhoods. Make sure that we can actually start bridging the relationships between those two different groups. What historically has happened is there's been a significant chasm that exists between those that have access or influence over resources and those who don't. And I think one of the things that can be done is by realizing that we're all in this together. Let's have some additional conversations, bring people together where we can talk about how to most appropriately utilize resources to make sure that the underserved communities will have the same level or access to testing, same access to medications, same access to primary care treatments, and all these other things, as well as looking at the economic devastation that potentially is on the precipice, and making sure that as we address the first phase, which is looking at the medical crisis, having those conversations for the second phase, which is the potential economic crisis, and the change in people's mindsets of how we interact with each other. So some of those conversations to start, you may not have the credibility with the community, underserved communities at this point, but trying to, and there are a number of individuals and organizations who are out there and willing to have these conversations. So let's start talking, let's start figuring out what we can do, start mobilizing some of those resources, and now be able to bridge that relationship so that as we start to normalize in this city and in this country, we can start working on what I referred as a restorative health equity plan.
What plan does MCW and/or the Milwaukee Health System have in place for after COVID-19? If so, what does that look like?
That's a good question. I think all of the health system leaders, the clinic leaders, and the medical and public health community know we need to do better. And I think one of the things Dr. Izard and I have talked about over the last week or two is how do we build trust and the connections so that when we have a crisis, you actually know who you can go to, who's going to be a reliable person. And so I think as we get on the other side of this, we really need to be intentional about building those bridges. I'd love to hear more from Dr. Izard because he really said some amazingly insightful things to me over the last week or two that I think would be important for the community to hear.
Well, I guess we'll discuss them as the questions come up.
All right. Next question is, do you think the beds that are now being constructed at State Fair Park are going to be needed for COVID patients? From last week's presentation, it sounded like Milwaukee is going to peak this week, so it doesn't seem like those beds would be ready in time.
I am hopeful we won't need those beds. It was a good safety measure for us to have in the community in case we had a surge. But I want to get back to where we started. This community has really done everything that they can. The people here have done everything they can as individuals to slow the spread down, especially considering the explosive initial growth that we had in the African American community. I think that the leaders of the community really helped people understand what they needed to do. So I think it's very likely we've peaked. That the variable we need to worry about, though, is what happened with the election, which we won't know for another couple of days probably, and what happened over this last weekend when people maybe relaxed a little bit because they wanted to spend time with their families during the religious holidays. That's going to be another week for us probably before we know.
A couple of questions about our healthcare workers on the front lines over at Fredert. Do the staff at Fredert have enough PPE?
We have enough PPE, but I think what everyone needs to understand is we have changed the definition of what's enough. We've learned how to reuse N95 masks and conserve gowns, gloves, goggles, face shields, and those other things, and to maybe change our workflows so that we don't use as much. I see Dr. Sanchez nodding, and I also heard a lot about this at the very beginning of the crisis from Dr. Izard. And he was doing some, at the time, I thought, very innovative things to make sure that he preserved his personal protective equipment for his staff. Tito, do you want to talk a little bit about that? Because I think you were really on the front lines and trying to innovate for protecting the supply that we had.
Yeah, I think all the fairly qualified health centers, we're speaking regularly, in addition to our health systems, of trying to have a better understanding of what people's needs are and trying to identify, again, because we're not doing screening tests for the COVID virus, we're doing diagnostic testing, but trying to ensure that for those patients from the list I just mentioned, especially those that are higher risk, looking at our various testing supplies by being able to sort through those patients who can potentially get into trouble a lot faster. Certain patients, by us being able to, at the community level, knowing our patients, being able to follow up with them, even potentially daily, to see how you're doing, can, if the person was able to stay at home, in the isolation and not necessarily get the test, then by continuing to work with the patient, we may, that person would be considered what we call presumptive diagnosis, but wouldn't necessarily need to get the test. And that way we can preserve the supplies, the PPE, and for the test for those patients who have the most risk factors that I went through the list before. And then at the clinic level also, which is much easier than in a hospital, by being able, some of our FQHCs have been able to establish on the outside of trying to identify people before they physically come in and be able to keep inside of the clinic safe, be able to get the swab done, you know, in the parking lot or in the car if somebody was able to drive. And that way, especially if you can do high volume in that respect, it allows us to preserve some of our PPE for our staff and with the equipment.
I've also really admired some of the businesses that have stepped up to use their platforms in very creative ways to manufacture PPE, such as face shields and other ways of protecting your eyes if you're working directly with a patient. We're reusing gowns as opposed to using all disposables, really creative things that our clinic managers and staff have done, just like Dr. Izard has been saying about minimizing that use. We've limited the number of individuals who are providing direct care for patients so that there's not redundancy there, and that only things that are absolutely medically necessary that need to be done in person are done. And we're doing the same thing for the outpatient clinics as we are on the inpatient side and the medical intensive care units. So a lot of efforts both outside hospitals and clinics as well as within.
Yeah, and one of the, and that's why the importance of having a primary care provider, someone who you know prior to developing symptoms, is so important, because in many cases, actually undergoing the diagnostic test is really not necessary. If you are relatively low risk and you have very mild symptoms, then the test, I mean, we're all interested in wondering what does the test say, but the reality is that that test is not going to give you any additional information than you know right now. So one of the things by having your primary care clinic, by being able to talk with them and tell them the symptoms you have, and if you had a known positive close contact exposure, then just being able to talk with your doctor or your healthcare provider and say, yeah, well, you probably do have this, but your symptoms are really mild, you know, let's have you stay home, and then go through the recommendations there. Most people are just fine with that, especially if they know that you're going to follow up with them within, you know, a day or two. And if they did develop worsening symptoms, they can come in and you would have a test available for them. So we found at the community level, having that open dialogue with people really has worked, reduced the utilization of the test, because having the diagnosis but the treatment plan being exactly the same, you know, it allows us to use it for those who truly need it, like the hospitals.
Thank you. Is there information on what % of frontline workers are testing positive?
Yeah, I don't think there's any, I've never seen, up to this point, I haven't seen any national presentation of information like that for a couple of different reasons. Kind of piggybacking of what we were just saying. For one, healthcare frontline providers are doing the best that they can to try to stay healthy and safe. And those that may have been exposed to someone who was positive, meaning that they either didn't have the proper equipment, or at the time they didn't know that the person was symptomatic or has symptoms. In many cases, based upon the staffing needs going on nationally, those providers are doing everything to keep themselves safe and their colleagues and other patients safe, meaning that they may isolate for 14 days. So in those cases, you still wouldn't necessarily need to be tested, especially if there's a shortage in your particular community. You would just do the isolation. So I don't think there really is a good way of truly knowing how many healthcare providers, and that's where the antibody test may have some utility of being able to look at in high communities where the COVID virus is present, being able to use antibody tests to get an idea of who may possibly have been exposed and therefore have the immunity that Dr. Sanchez was just referring to. But again, all this is taken with a grain of salt and in the context of a much larger conversation. No one data point should dictate a whole meaning of the story.
One more testing question. We hear in the media about children being asymptomatic carriers. Should we be testing children to find out whether they are spreading disease?
Well, yeah, go ahead, Dr. Sanchez.
No, please, please.
Well, I was just going to say, again, we have to be careful with certain statements that that have a morsel of fact to them, but they're not the whole truth. So yes, young people or children may not have the degree of complications, but it does not mean that they still aren't being impacted by the virus. All right. So I think it's an oversimplification if we start thinking of children as being these little asymptomatic carriers walking around, when the reality is, yeah, they could be carrier or they just had mild symptoms. When you talk about children under 10, as a parent of 4 kids, kids always have some type of cold symptoms. So you don't know if they had actually mild symptoms or was this the coronavirus, right? So many times as a parent, if the child's if they don't have a fever and they're not complaining, they're good to go. So I just think we have to be careful in overstating that children are always going to be well, and we should treat them just like everybody else. We identify you, what are your symptoms, and make sure we monitor you to make sure that you stay safe and well. And then when there's enough antibody testing around, that's something to think about. But also, will parents want to get their kids poked in order to check for antibodies? That's going to be a whole nother social conversation.
Yeah, I 100% agree with you. I think children, if they develop severe enough symptoms, I don't know that we would classify them any differently than an adult. Now, granted, I'm not a pediatrician, so I'll just or a family medicine doctor like you, but if they're sick enough and there's not an alternative diagnosis, I think they absolutely deserve testing just as an adult who, and if there are concerns enough where the child is in respiratory distress, a fever that won't go away, if they're unusually fussy, in addition to looking for COVID-19, there are plenty of other viruses and bacterial infections out there. Personally, being a mother to a kid who's had multiple ear infections. So we can't lose sight of common things being common before the era of COVID-19 too.
And those who may be interested, if you actually go on in Wisconsin's DHS website, they have a really nice report that shows the surveillance data for the typical virus conditions that are out this typical season. And when you look at that, it's a great reminder for anyone in healthcare, as well as those of you that are just interested, of being able to remind yourself how many different things are typically seasonal. And for example, RSV, respiratory syncytial virus, which is very common in children around this time of year. So you may not know that your child, they could have any one of these various conditions. And in the end, like Dr. Sanchez just said, you want to make sure your child is doing well. So as long as they have mild symptoms, then you would treat them appropriately and with conversation with your healthcare provider, and make sure that if they didn't need further testing or intervention, that we can respond. But this time of year is extremely common to see other viruses. We have to remember that nationally, only 1 out of every 5 people who had symptoms and were tested for the coronavirus 19 actually had the coronavirus. That means 4 out of 5 people did not test positive, and therefore potentially it could have been something else.
Okay, thank you. These next sets of questions will deal with masks, social distancing, and other things that the community can do for protection. I am hearing that the safe distance may be extended from 6 feet to 13 feet. Can you speak to this?
I haven't seen any literature yet that talk about 13 feet specifically. I am aware of the data related to, and maybe some of my colleagues can speak further on it. So in general, when we talk about the COVID-19 virus, we've heard it mentioned very frequently as a respiratory droplet, which talks about, and without getting too scientific, about the size of the particle. And so looking at the typical for the average person that has the infection, that size of that particle will, based upon its size, it'll fall to the ground from speaking, coughing, and sneezing, most normal common things, will fall to the ground around 6 feet. Now, of course, certain things like a sneeze could potentially produce a larger number of respiratory droplets. Other types of things can actually cause the nuclei of that virus to stay in the air longer. But for the average layperson, it's typically a 6-foot distance respiratory droplet. In healthcare environments, and that's why we encourage people to not go to hospitals and to the clinics if you don't have to, because you can think, obviously, in those environments, you have the sicker of the patients, and we have a high volume of sick people. Potentially, those respiratory droplets can stay in the air for a longer period of time. And so we try to encourage people to so it's still a respiratory droplet, but there are situations that it can stay in the air longer. So sometimes there's a lot of confusion regarding, well, is it airborne? It's not the same thing as some of the other conditions like measles or tuberculosis and those types of things. But if it's in the air for 30 minutes, you don't know who was in that air prior to you. So that's why we're recommending now, as we learn more about the virus and how long it may remain on surfaces or be able to circulate in air, especially in high volume areas where things are constantly moving around, that we're recommending to people to use the homemade mask. And my recommendation has been, if you can look through the material, then that material is not good enough to protect you. So in other words, people are using their sweaters to pull over their face when they walk up. Trying to use a cloth product, you can use a homemade mask. There are a lot of great ways, a lot of great YouTube videos that'll show you how to do it inexpensively and very safe. But Anthony Fauci and Dr. Jerome Adams, the US Surgeon General, they both talk about the homemade mask, which is going to be great for the vast majority of the population. Those homemade masks are used to help protect other people from you. And when they use their mask, that homemade mask is to protect you from them. The medical and surgical mask that we use in a healthcare environment is used both. It's to protect our patients from us as healthcare providers, because who knows, we want to make sure that we don't expose you to anything before we even know we had symptoms, and to protect us from you. And that's why we want to ensure the proper use of the proper types of materials. But for the average person who's walking around the community, going to a grocery store, those type of things, utilizing your homemade mask. I mentioned before that if you look at the head of a needle, a pin needle, that for the most part you can get 50 to 100 of those virus particles on the head of a needle. So if you have something that's covering your face that has lots of holes in it and is bigger than the size of a needle pin, then that's too big. You need something that's a lot better, like cloth.
Thanks, Dr. Izard. I did want to answer the second part of the question. I don't think the recommendations are going to be changed. The 6 feet recommendation has worked. Social distancing is working well in the country, and so they're probably not going to change it. I think the question was a result of a study that was done in that temporary Wuhan coronavirus hospital, where they said that the droplets could disperse about 13 feet.
A follow-up to the to the homemade cloth masks, how would I sanitize a cloth face mask?
I think the recommendation is
So
just
I
to
think,
wash soap and water.
yeah, good old soap and water.
Someone confirmed positive with the coronavirus gave me some masks. They are still in the original packaging. I've left them in my trunk. Are there any issues with using them?
No, especially if they've been sitting in your trunk for a few days. The virus particles, you probably have heard that it may remain on certain surfaces for a certain time period, but if they've been sitting in your trunk for 2-3 days, they're just fine.
How
Just
long
make sure
are
you wash
people?
your hands before and after you put it on.
Yep, thank you. How long are people with COVID-19 contagious?
I think that's a question that we all wish we knew a definitive answer to. For the most part, what we're seeing is that virus can be shed from the upper respiratory tract for 7-10 days. In some studies, mostly out of China, where they have still the most experience yet, people can shed virus for up to 21 days, and there are a few outliers who are even longer. Some people have suggested that there may be reinfection if they stop shedding and then restart shedding again. And to be honest, the medical and scientific community as a whole doesn't think that's likely, and that the initial negative PCRs or the swabs that were done that were negative were probably sampling error or some degree of variability from hour to hour, day to day, and how long someone sheds. What we don't know is that just because you shed virus at 21 days, are you actually still infectious? Particularly for the critically ill who have had severe lung disease, severe lung damage as a consequence of their severe viral pneumonia. They can have dormant virus, basically dead virus and residual DNA for that long. At this point, I've not seen any convincing data beyond a couple of weeks that people are still infectious.
The recommendation that most of us are going with, though, is, and again, for an average person, we're recommending that if someone had symptoms and let's say they tested positive, we're recommending that they remain in isolation for at least 3 days after their fever goes away and the resolution of their symptoms that they had. So if they had cough, that their symptoms have resolved, and at a minimum of 7 days at least. For hospitalized patients, maybe a little bit longer, and sometimes patients who are hospitalized will be discharged and recommended to continue wearing a mask. But for most of us in the community, that's the recommendation from the CDC.
Regarding the safe at home initiatives, what are the determining factors to ease those? And what is the contingency plan to mitigate risk once that ends? Will we need to wear masks until there's a vaccine?
Really great question, and that's something that our local chamber is working very hard on in collaboration with the health systems and with MCW. There's some must-haves. We must have enough personal protective equipment for the healthcare providers, first responders, and anybody that might go back to work in a high contact area where they might run into other people. We need testing available for everyone. We need capacity in the ICUs of our local health systems, and we need good public health follow-up so that if somebody is tested positive, that all their contacts can be traced. And we're at varying degrees right now being able to deliver on those must-haves. So rather than looking at a date, we've been trying to say, what is it that we need to do to responsibly reopen parts of our economy? And then the second part of the question is really a smart one. It's like, okay, what do we need to do to make sure that we don't have another surge? So we have to be very careful about that. I think we're going to be wearing cloth masks in public for a while. I think it's a good idea, and until we have better testing and we have this under better control, that we're probably going to keep doing it.
Now, the next question is regarding hydrochloroquine. There's been a lot of information out there regarding its effectiveness. Can you speak to this, and in particular, those with autoimmune conditions who've already been using this for long periods of time? Have there been any indicators of preemptive protection due to using this drug?
Well, let me just say the topic has been politicized because people are desperate for a cure. All of us are. I would say that if you're a scientist, you would say that the evidence that it is helpful is not good. But there are other people that have taken some hope from some very small, uncontrolled studies. And again, this is a desperate situation for many people, and folks are just looking for something to use. We don't want to use so much that people that already are prescribed it for approved indications don't have their medicine. So that's one consideration. And these medications do have side effects, especially cardiac side effects that can be life-threatening. And so what I think all of us want to do is rely on our physician or our healthcare provider to make that decision with us.
Great, thank you. We just have a couple of minutes left, but I do have one specifically for Dr. Izard. What do we need to do for our families on the north side to ensure they have better health care?
Well, that's a great question and not an easy question. I think one thing we need to do is to be able to start having honest conversations at our political level and in our healthcare system to start thinking through realistically, what are people supposed to do? And I think what we've done for years is I refer to it as malignant indifference. That it's not the same as racism, where someone doesn't like someone and they really mean harm to you. But I think what's much more common is something malignant indifference is that we have the ability to positively influence people's lives, but we choose not to do that because it will require us to sacrifice something. And until we actually have that hard conversation of saying, well, what's the sacrifice necessary to ensure that that people who've been part of the permanent underclass in America forever have access to high quality healthcare? Until we start having that realistic conversation, this is just going to be a circular issue. So we need to, and that's why I said it has to be a restorative health equity. So restorative means to bring to a level of wholeness that we were before. And so if we look at the African American population, those that have lineage to historical slavery, Jim Crow, redlining, and all of such things, never in the history of this country or the preceding development of this country have this population and their descendants ever had a certain level of parity when it relates to health care. And so when you look at it like that, it makes a whole lot of sense right now why there's so many problems. So in order to actually truly to eliminate health disparities or to create parity, equal outcomes, then we have to have a restorative health equity plan in place to be able to address that. And because it's so closely connected to economics, the economics has to be addressed. When in the United States, 50% of Black people in the United States have zero to negative wealth, how do you ever get health equity? You can't with that, because people, it is not your, and that's why I said earlier, wealth is what stabilizes you. It's not your income, because we're finding that out right now. If you lose your job temporarily for even a few weeks or potentially a couple of months, it is your wealth position that stabilizes you and your family because you're living off your savings. But if you had an income and your income stops because you were you were making a good income, but you were a hostess or a waiter, and now the restaurant shut down, you have very little to sustain you. And so we can't have a restorative health equity plan without addressing it in the context of economic parity in the United States.
Thank you, Dr. Izard. We are at time. I'm going to turn it back over to Mr. Corey Nettles to close us out.
Great. Well, another informative evening. Our thanks to our panelists, Dr. Sanchez, Dr. Raymond, and Dr. Izard, for enlightening comments, not only about the COVID pandemic specifically, but also about the impacts in our community. Dr. Izard, I especially have appreciated your references to restorative health equity. I'm going to spend some time reading up on that on my own. And thank you for being such an important asset to our community and for joining us on our Medical College of Wisconsin Town Hall. So thank you all again to our panelists and to those of you out there joining us at this Town Hall. We'll look forward to a similar conversation again next week, Monday. And in the meantime, this broadcast will be that has been recorded will be uploaded onto our website, as well as we've had running frequently asked questions at that site as well. So thank you all for joining us, and we hope that you all will stay safe. Take care.
Thank you for the invitation.
Thank you.